investigating joint position sense in individuals with asymptomatic forward head posture. Thank you.
Okay, good afternoon to all present. My name is Priya and this is our group's research topic, investigating joint position sense in individuals with asymptomatic forward head posture, a pilot study. This is the content of our presentation. First, we will begin with the background of our current study. The objective of our study is to find a correlation between forward head posture and joint position sense. Forward head posture is a common clinical phenomenon present in neck pain. It also serves as a good clinical indicator of one's posture during objective examination. So what is forward head posture? It is a posture presenting with an increase in upper cervical extension, flattening of the lower cervical spine, elevation and protraction of the shoulders and excessive thoracic kyphosis. Our group decided to do a study on forward head posture because it is a commonly adopted abnormal posture. So why is forward head posture perceived to be so bad? This is because it results in altered alignment and biomechanics, neck muscle imbalance and stress on passive tissue. This translates into an increased incidence of neck pain. So why the interest in proprioception? Our literature review revealed that joint position sense is a novelty in the area of the cervical spine. Research has also shown that joint position sense is an important component in correcting forward head posture. Proprioception encompasses both joint position sense and kinesthesia. Kinesthesia is the ability to sense body movement, while joint position sense is the ability to reproduce joint angles. In our study, joint position sense was measured to quantify cervical proprioception. Just like in forward head posture, impaired joint position sense has also been associated with an increased incidence of neck pain. This slide shows the different factors that affect joint position sense. Research has already established a relationship between gender, injury, fatigue, pain, age, vestibular input and tactile input. However, the relationship between joint position sense and forward head posture has not been established. Hence, we investigated the joint position sense in individuals with asymptomatic forward head posture. Therefore, our null hypothesis is that there is non-significant correlation between forward head posture and joint position sense. And our alternate hypothesis is that there is significant correlation between forward head posture and joint position sense. Our independent variable is the forward head posture, which is measured by the craniovertebral angle, and our dependent variable is the joint position sense. So the craniovertebral angle is the angle obtained between the C7 spinous process and the tragus of the ear as shown on the diagram here. Forward head posture is quantified by a CV angle of less than 46.6 degrees. Our dependent variable, joint position sense, is measured by the degree of mean joint position error, also known as mean JPE. Next, methodology. I would now like to bring you through the instrumentations used in this project. The first will be the 2D silicon coach, which was used to quantify the CV angle. The 2D silicon coach has been used in various studies to measure and evaluate spinal angles and postures. In our study, it was used to measure the CV angle. The 2D silicon coach is a commonly used tool by many researchers and has been shown to have high reliability and good construct validity. So a CV angle of less than 46.6 degrees would indicate the presence of forward head posture. The next instrument used was the Rebel visual technique, which was used to quantify cervical joint position sense. This instrument was designed to evaluate cervical joint position sense involving movement and position of head relative to the trunk. In this technique, participants were required to wear a hairband with a laser pointer fixed on it. This technique also has a target board on which measurements are recorded. This is the target board of the Rebel visual technique. If the participants have an error of more than 4.5 degrees as reflected by the red zone on the target board, they are considered to have an impaired cervical joint position sense. Research has also shown that this technique has a good intra-class correlation coefficient for its test-retest reliability, inter-observer and intra-observer reliability. Therefore, cervical joint position sense is quantified by a mean joint position error of more than 4.5 degrees. Moving on to our subjects, we recruited 71 participants from Nanyang Polytechnic School of Health Sciences. after which we screened them using our exclusion criteria. One of our exclusion criteria tools was the Neck Disability Index, the NDI. The NDI is a questionnaire on the functional status of one's neck. It has 10 questions and a score of 0 to 4 indicates no disability. Research has shown that this tool is reliable and valid in measuring subjective neck pain and disability. The next exclusion criteria was done subjectively through an interview. Any subjects with any of the following medical conditions were excluded. Participants who had a history of head and neck surgery, fracture or trauma, any diagnosed pathology of the spine or temporomandibular joint, neurological signs, or were on medications that cause drowsiness were excluded from this study. So out of the 71 subjects recruited, only 59 of them were included in the study. 12 of them were excluded because they had a score of more than 4 on the NDI. And out of these 59 subjects, 39 were non-FHP and the remaining 20 had forward head posture because they had a CV angle of less than 46.6 degrees. Next, the experimental procedures. So when the subjects entered the room, they were briefed about the experimental procedures and were asked to fill out the NDI and to declare if they were diagnosed with any of the previously mentioned medical conditions. After which, they proceeded on to the next station for photo taking. Here, they had reflective markers placed on their C7 spinous process and triangles of the ear for measurement of their CV angle. They then proceeded to the other part of the room, which was cordoned off with a full-length blinder so as to eliminate any disturbances coming from the previous stations. Here, the tester placed a headband mounted with a laser onto the subject's head. They were seated on a chair placed 90 cm away from the target board with their eyes closed. Subjects were then asked to assume their comfortable head position. They were told that this would be their neutral head position. The tester then gave instructions for head rotation. When the subjects were asked to return to their neutral head position, another tester marked out that spot on the rebel board. The tester who gave the instructions then repositioned the subject's head to the neutral head position, regardless of whether they managed to return to their neutral head position. This process was repeated 10 times, 5 to the left and 5 to the right. It is to note that the participants kept their eyes closed throughout the entire procedure. That marks the end of the experimental procedures. A mean joint position error of more than 4.5 degrees as reflected by the red zone shows an impaired joint position sense. I will now pass on the time to my group member Bernard, who will discuss our results and limitations and thereafter conclude the presentation. Thank you.
Thanks, Priya. Good afternoon, one and all. Now I'd like to direct attention to the results for both forward and non-forward head posture groups. For the FHP group, a positive non-significant correlation between the mean joint position error and the cranial vertebral angle has been found. As mentioned by Priya earlier, the mean joint position error at the y-axis is the dependent variable, and the cranial vertebral angle at the x-axis is the independent variable. I would like to direct your attention to the gentle positive gradient of the graph and also the positive R value at the correlation found using the Pearson's correlation. Both points to a positive correlation. However, the significance level, as reflected by the p-value, is greater than 0.05. This would render the correlation non-significant. Besides, a mean of 4 and a standard deviation of 1.28 are obtained. Similarly, for the non-FHP group, a non-significant positive correlation between the mean JP and the CV angle is found, and a corresponding mean of 3.93 and a standard deviation of 1.59 are obtained. Looking closely, the mean joint position error for both forward and non-forward head posture groups are found to be less than 4.5 degrees. This would imply that the joint position sense is not impaired in both the normal and the asymptomatic forward head posture subjects. On a side note, the normal subjects still perform better with a smaller mean JPE of 3.93 degrees as compared to 4 degrees found in FHP subjects. In summary, the non-significant correlations found in both instances indicates that joint position sense is not impaired in asymptomatic forward head posture subjects. Hence, we accept our null hypothesis. It is interesting to note the positive trend, whereas the cranial vertebral angle decreases, the mean joint position error also decreases. This would mean that as the head posture approaches one of the forward head posture, the joint position sense actually improves. This brings us to the discussion for this improvement in joint position sense. The first reason that I'd like to touch on is the altered joint biomechanics as observed in FHP. In this posture, there is upper cervical extension and lower cervical flexion. The extension closes the facet joints, compressing the joint capsule. On the other hand, the flexion opens the facet joints and pulls the capsule apart. Both end range movements actually increases activation of the joint receptors, contributing to an increase in joint position sense. The second possible reason for this improvement in JPS would be the shortened posterior neck muscle as observed. Research has shown that there is an increase in muscle spindle activity in these shortened muscles, which once again contributes to the improvement in joint position sense. Certainly, we acknowledge the limitation faced in our study, which is the non-uniform sample size used for both groups, and it could have influenced the results. Next up, for some insights we have gained from our pilot study, we detected an improvement in JPS in individuals with asymptomatic FHP. This is opposed to the abnormal posture as observed in FHP, and also the consequence of improvement is unclear. It could be a scenario where there is a range of JPS values and a pathological limit exists. The thing is, we never really know. An overview of what I've covered so far, there's a positive non-significant correlation between joint position sense and forward hip posture as established in asymptomatic individuals. Nevertheless, the underlying mechanisms remains obscure, though a few reasons have been speculated earlier on. Further research is definitely warranted. Interesting areas that future study could look at could include isolation of neck movements and also looking at different planes of movement, as the natural head movement comprises of movements in different planes. So by scrutinizing the different planes, you can get a better picture of the joint position sense. Thank you very much. That marks the end of our presentation.